also, we'll talk about pharmacology is our first domain that we have as well. So I know that some of you guys joined on time for the course, and some of you guys joined a little bit late, so you may not have finished the first week, which is totally fine. So I will warn you that the first 2-ish weeks, maybe even the third week, are a little bit intense. And so it is okay if you don't finish each one necessarily on time each week. Just try your best to kind of get those guys done. And you guys can always work back and get the rest done. It's kind of set up like a course, like you're in school, but it's not like I'm gonna come down hard on you like you're in college. So, but I do care that, hey, let's try to get this stuff done, work back, try to stay, okay, I didn't finish pharmacology this week. Start then on anesthesia so that you can try to keep on task, but go back to pharmacology and try to get the rest done as well, because it's important to do as all of that as possible, so you can recall all of that information. When we do come on Sundays, we'll try to mainly focus on like that week's stuff, but we can always go back to things that you guys still have questions on. So like math stuff, things that we talked about the week before, because it's important that we still, go over those things multiple times so that you guys continue to get that process over and over in your head. So I will probably ask you guys, like, what are the main things that you guys have questions on for that week? And then also, what are the things that you want to go over from previous weeks that you still are having questions on, if that makes sense? So first, let's start with, what questions do you guys have about the course itself? Does everything make sense to you that I kind of explained? Or in like the intro, did you guys all watch like the intro video that I made like a long time ago? Okay. Did that all make sense to you guys? Like how the course looks and all of that? Any questions?
I personally like the Picmonic videos.
Yeah, aren't they fun?
Oh.
Yeah. Okay, so the guy itself, I want to be best friends with him because he sounds like he would be so much fun to hang out with.
With the pocketbooks, I'm trying to figure out, do you fill them out as you go per category and keep them per category?
So great question. So with those, I kind of set up the categories in such a way that I felt like made sense to me. However, you guys can do it any way you want. So these books are completely for you guys and your studying. So if you guys want to change up the categories and do the way that makes sense to you, go for it. But I think what is the best way to do it, though, is write the book as we're going through and learning, so that it's kind of like your little cheat sheet notebook, so that you can look through this book and study. And the book isn't necessarily to write down, like, if we're doing anesthetic drugs, that you're writing down like your alpha 2s, like dexmedetomidine, and writing everything you know about it, but it's recall things. Like, what about dexmedetomidine is going to make you recall what it actually is, right? So if it's just a couple words, even if it's like a picture that makes you recall what it is, that would be perfect. But you don't want it to be this lengthy Bible type of thing. So
Right.
if that
How
makes
do
sense.
we submit it to you? Do we just take pictures and email it?
Yeah, so you can either take a picture of it. One person even just made a video because it was easier to just kind of flip through. So you could do that. And then Moodle's kind of weird about it because it's hard to like upload big files. So you could just email it to me. So
And
yeah.
how often do you want that email?
So I said in the thing to just, we'll do check-ins and stuff. But you guys can just email that to me just at the end of the class is totally fine. There are times where, like on here, people even just like show off their their books, or even on our Facebook page, the Crash Course page. People even share like what they're currently doing, which is nice because then other people are getting ideas too of what they can do. Or you can even say like, hey, this is kind of what I'm doing, but do any of you guys have better suggestions? Or like, what are you guys doing in this section? So, I mean, it doesn't necessarily have to be secretive or like you're cheating off of each other. It's all about like helping one another to do something that's going to be awesome for you guys as a good study guide. So, and I want you guys to have this so that you can utilize it, you know, in practice. So, I mean, it may be, this one may be kind of messy, so you can always make a finalized one down the road. So, yeah. Nicole, you raised your hand. So funny. Love it.
Sorry, this is my first time doing Zoom. So
I love it. No,
I'm trying
it's
to
great.
figure everything out.
It's the new world.
It is. I never got the email for Moodle, so I'm really
Okay.
behind with everything
Okay.
for today.
It's not in like your junk folder even or anything like that?
No.
Oh,
Yeah, I've been
God.
checking daily.
Okay, I'll write your name down so I can, what I'll do is like rewrite your account and send you that right after our session. So we'll get you caught up.
Okay, cool. Thank you.
Don't worry, you'll be behind, but it won't be that behind. I'm sure there are other people who are just as behind. So we'll get you caught up. Is there a folder where the PowerPoints are from your lecture videos? Good question. And that might be something I can do. I will work on that, Julianne. Very good idea. Juliana, sorry. PowerPoints.
On May 31st. Let's work on week 1 content this week.
I will do that. Thank you, Juliana. That's a great idea. Oh, you don't have to turn on. You don't have to turn on your camera and ask. I do love seeing you guys, your faces, so that I know who I'm talking to. But not everyone is comfortable doing that. So, and I look crazy too. I just woke up and turned on my camera this morning because I have teenager daughters and they were in the bathroom. So, it's okay. It's Sunday. It's mom day. So, so great. Any other questions about the course itself? Awesome. You guys are on top of it. I like it. Great. So pharmacology always seems to be one of the struggles in this course. And pharmacology and anesthesia kind of go a little bit together. So that's kind of why I put them both together. So what are some of the areas that you guys feel are your struggles in pharmacology? If they're categories, if they're that type of thing, but what do you guys feel are like the struggles you have?
I think there are a lot of I took the VTNE once, and there are a lot of older drugs that I just didn't recognize, that I haven't worked with at all or learned about.
Okay. Got it. You're excited to have structure, Anish. Yes.
What about more like equine or large animal? Those
Large
would be,
animal.
oh, and exotics. I had a
Mhm.
question on the VTNE. I'm like, okay.
Yeah.
I have the opposite problem of what somebody else stated. We use a lot of, my practice owner is in his 70s and super old school, so everything we use is fairly old compared to, like, we don't use propofol or anything like that. So a lot of the newer drugs or newer pain management techniques, things like that, we don't particularly utilize. Like, we only started using, say, Kitty Magic in the last couple years because I use it on my cats and I like it that way. So I was like, we need to do this. So I just don't have a great familiarization with newer things.
Got it. Got it. Yeah. And I mean, there's kind of, yeah, I mean, there's so many drugs out there, right? There's just so many. And there's more that continue to come about. So that's kind of the crazy thing. So I think that having kind of a handle on the really basics, number one, is important. What the VTNE tries to do is also throw everyone for a loop on what we're utilizing these drugs for. So sometimes they will give you a question and throw an exotic in there or a large animal in there. And it's not necessarily just about the animal itself, but it's more about the drug. And so just making sure to calm your nerves, number one, and go, okay, this isn't about the horse, or this isn't about the guinea pig or lizard that we're talking about here. It's about the actual drug and what it does. So like, we need to focus on that. So that's one thing as well. And so, and also important is we have to know our drug classes, right? So when we talk about, did you guys watch like the antibiotic drug classes video?
Yes.
Okay. So that one's really helpful to watch and just kind of understand like what are some of the antibiotic drug classes and the ones that we, oh yeah, the drug controlled drugs schedules. So we'll talk about that for sure. Because that's really, really important, right? So and we'll go over that actually. So when we actually let me get rid of this. So I definitely recommend watching the antibiotic one so that you know those classes and what we use them for, right? And what certain drugs we can't use on certain animals. So like what drug should we be cautious with on like antibiotic drugs? Can we be cautious on with younger animals and antibiotics?
Enro.
Okay, so you said enrofloxacins?
Yes.
Okay, so if it's enrofloxacin, what drug class is that?
Or fluoroquinolones.
Okay, fluoroquinolones, right? But enrofloxacin is in what drug class?
Would that be the class, the fluoroquinolones? Or
It's an antibiotic.
Oh yeah, sorry, it is fluoroquinolone. Yes, sorry. I was thinking of completely something else. So yes, and so sorry, why do we have to be careful though of enrofloxacin or fluoroquinolones in young animals?
Does
because
it
it
have something to do with the bone, like bone and growth and things like that?
Great.
binds calcium.
Okay. And then what specifically do we see if they're given, at what age especially? What age do we have to be cautious with?
Is it 8 months and younger? Because they're still growing, because they still have the growth plates.
Okay.
Thought it was 8 years and younger.
It's not 8 years, because then we wouldn't be able to give enrofloxacin for like any animal.
Is it 8 months?
I just thought it was like 6 months, but
I
But
could
it-
be wrong.
yeah,
feel like-
I think
It
it's,
sounds about right.
yeah. So if it has effects on calcium, right, and bone growth and whatnot, what are some symptoms we see if they have had enrofloxacin? Like, say they come in, what would you notice?
Wouldn't their teeth turn yellow too?
Is that enrofloxacin?
That's like tetracycline.
Cycling.
Yeah, that's
Yeah, I think that's
tetracycline.
tetracycline.
Yes. But there is something with their teeth, right?
It's
Would they be less dense? or like-
hypoplasia.
Yeah. So the density of it is a little bit weird. And so they, the morels have it, right?
Yes.
Enamel defect. So the enamel on the teeth would not necessarily be there. So if an enamel's gone, what happens then to those poor animals? Can you imagine if there's no enamel on your teeth? Yeah, soft teeth, right? So what does that mean? Are they going to start feeling things on their teeth?
Painful.
Yeah, yeah, definitely. So personal note, my cousin has like a congenital thing, and she has no enamel on her teeth. So she can't eat certain foods, and especially like carbonated beverages she can't have. Not that your animal's gonna have a carbonated beverage, but she can't have certain foods because her teeth are so sensitive. Can you imagine a dog trying to eat snow or ice or whatever with no enamel on its teeth? I'm sure that's going to be quite sensitive, right? So yeah, you're right. Like that's probably a drug that we should know and be aware of, like a double check method on our end if a doctor accidentally prescribes enrofloxacin. So we're a great double checker, right? Because sometimes doctors have like 8 million things on their brain. So we should know that. Now, what is enrofloxacin? That's a generic name.
Atrial.
Atrial, right? It's our go-to drug for basically so many things.
Great for rats,
Especially,
too.
yeah, it's great. It's great. It smells interesting. What do we use Baytril for in what type of animals? For like pretty much everything.
Urinary issues.
Okay. What animals though that is our go-to drug? Like, you're gonna give Baytril to these animals all the time. I know this is like a weird question I'm asking.
I've given it to my rats. I know that
There you go.
they can use
Yeah.
it prevalently because they can take it orally. So
Yeah. So exotics, right? Exotics is like,
you can't give it sub-Q because
Yeah.
you can get tissue necrosis
Yeah. But yeah, it's like,
unless you dilute.
okay, so like, it's like, okay, if it's an exotic animal, we're probably going to give it Baytril, right? If it's some like infection, you're going to give it Baytril. So even if you are very like new to exotics, like I don't know too much about exotics, but I'm like, okay, I know like Baytril could be my go-to,
If they hear me talk.
Look at you. You said my clinic uses it with exotics. I see someone coming through. Hi. Hello. Oh my gosh, you have a Rugrats shirt. I love it, Kelsey. I was just talking to my daughter the other day about Rugrats. Like literally was like, it is on our channel thing for Nickelodeon. You have to watch that show because I grew up with Rugrats. It's like the best. Okay, sorry. Distracted already. Yeah, she was like, okay, Mom, whatever. Because she watches like terrible shows now, just awful shows. She's like, oh gosh, never wearing Rugrats shirt again for Beth. Awesome. So, okay. What is our other drug, right? We talked about yellowing teeth. What was that again?
Tetracyclines.
Tetracycline. So what is one of our tetracyclines we use a lot?
Doxy.
Doxycycline, right? We have another one that's like doxycycline that we have used because doxycycline sometimes likes to become really expensive. So what's the other one we like to use sometimes? It's very similar to it. Starts with an M.
Minocycline.
Good, minocycline, right? Very good. So what do we use doxycycline for a lot?
Tick-borne.
Yeah, tick-borne things, right? Especially. Yes, yes, yes.
Or like things like chlamydia and cats.
Okay, very good. What else do we use it for?
Heartworms.
Heartworms, very good. So why do we use it in heartworm? Like, does it kill heartworm?
When they die off, don't they like release proteins and bacteria and stuff into the system and it?
Yeah. So we want to try to like minimize that bacteria that those heartworms are going to release, right, ahead of time. So we usually give them doxycycline first for 30 days, and then we're going to go ahead and treat them for heartworm, correct? So that's
Like
awesome.
Bacterial static where it doesn't allow the bacteria to grow.
I would believe so, yes.
I think Doxy is. We have in my clinic, we're part of the American Heartworm Association,
Okay.
and we were in a trial with Bayer when Bayer was still Bayer. Now it's Elanco, but we do a series where they're on so many weeks, off so many weeks, and then in between they actually use Advantage Multi because it actually kills the adult worms. So it's actually a 6-month protocol of
Okay.
an intermittent doxy and monthly multi. I actually do the heartworm protocol with them.
Okay.
I think the short amount of time I had it with multi and doxy without the aminoside injections. My shortest time period was 6 months, and that was confirmed by lab and heat fix.
That's awesome. So when was this study done?
I believe it was 2017 or 18.
Huh.
Yeah.
And have they released all of that?
I can send you my protocol so you can
I
see.
would love that. Yeah. So have they released all of it?
You?
You can look up their website,
Okay.
and it's on their Bayer website.
Okay.
We had a lot of success because people don't want to have to like cage their dogs, and with this protocol you can space out the pricing. It's about, in my clinic, it's about $1,300 for the full treatment, but you can divide up the treatments. We would script out doxy and give them good RX, and their prescriptions are like $18.
Yeah. Yeah, because doxy can be extremely expensive.
And
a aminoside treatment is not cheap either.
No, but you have to pay for it up front because you have to buy all 5 vials at one time.
And it's super painful too. Like,
yeah, and there's downtime with this. Like they will run and be dogs. The only thing I tell my clients is you just got to be patient.
Yeah. Interesting. Yeah. I mean, I have not seen that done. So I would love that if you want to
I'll send you my protocol.
I would love that. Awesome. No, I would love to, because I love sending you guys like all, you'll see as we go through, there'll be so much stuff that I just like put in there that your guys are like, this is not on the VTNE, right? And I'm like, nope, because I don't think that this course should only be about just the VTNE, but it's about sending you guys to your first job as a CVT, LVT, RVT. And having a ton of really great information to be able to collaborate and critically think through your job. Yes, I want you to be prepared for the VTNE, but you don't stop there. So I want you to have a lot of great resources. And as we talk through this, you get the information, but I want you to be really well-rounded. So I love that you are telling me all this stuff because it makes me continue to learn. So that's awesome. So thank you. I would love to see that. Super cool. And to be perfectly honest, like I've done heartworm treatments when I was teaching, but even just in my career, I was in specialty. So I didn't have to do a lot of heartworm treatments and stuff. So I think that's really awesome. And we did heartworm treatments only in the educational setting, and they were just for, Humane Society ones. And so we only did aminicide because they could cage them. So, all right. So fantastic. So what else do we do doxycycline for? I mean, we use doxycycline for a ton of stuff. But doxycycline we'll use for upper respiratory infections, right? So yeah, look at you. Great. So like, any type of upper respiratory, right? So especially in shelter medicine, they use doxycycline like candy, it seems, right?
We use it at our cat shelter a lot. We had a couple
Yeah.
cases of pneumonia.
Yeah.
recently.
Yeah. So, I mean, it's used a ton. But again, we have to be really cautious because we can't use it in our really, really young guys. But it is used quite a bit. And the downside to it is that you have to use it for a longer period of time. Just kind of how Emily said, is that it's bacterial static. So it means that it's not going to kill your bacteria right away, but it's going to prevent it from producing additional bacteria. So that's why you have to give it for longer periods of time.
Does
So
it gram negative and positive too?
yes, yeah. And yes, you're right, Melissa. We use it on exotics as well. Very good. So it is really great to be able to use in many, many areas. Now, what do we use? What is our main drug choice that we use a lot for antibiotics?
Amoxicillins.
Okay, so like our penicillin category, right? And so that would include amoxicillin. And so what are those drugs that we have on hand typically? Like we have amoxicillin. What else?
Oh,
Clavamox.
Clavamox, right? So what's the difference about Clavamox and amoxicillin?
Clavamox has clavamate something mixed in with it. It's like Augmentin for humans.
Great. And so what are some of the downsides to and then we have Peng, of course, too, right? So we have penicillin itself as an injectable. And so what do we use these guys for?
We use it for upper respiratory sometimes in cats if it's like more mild ones and we don't want to hit them with something huge.
Okay.
We've used them for bladder infections, for urinary stuff. Again, generally if we want to start somewhere low and slow versus just
Great.
while we're waiting for cultures or whatever.
Great. And so what is like a great benefit about using a penicillin? Are they bacteriostatic or bactericidal? They're bactericidal. So that means that they're going to kill bacteria right away, right? So some people use like our penicillin before surgeries or all of that stuff, just in case kind of thing. So that they can kill any type of bacteria. And so we don't have to necessarily give amoxicillin or Clavamox and stuff for a long period of time. right? Because it should kill that bacteria and be done with it, correct? So we shouldn't have to do Clavamox or Amoxicillin for 3-4 weeks. We only typically do it for how long?
Like 10 days, 10 to 14, I think on average.
Yeah, and the most, right?
Yep.
Yeah, great. And in humans, people feel better after 7 days, and then what do?
They stop taking it immediately.
They stop taking it, right? Because they feel better, which they shouldn't do, but they do.
On them.
Right? Yeah, exactly. We're the worst patients ever. Seriously. Okay, so what are some of the downsides to amoxicillin, Clavamox, that type of thing?
Resistant.
Sorry, what did you say?
They're more resistant.
They're more resistant. Yeah, right? So that's why we do cultures and stuff too, right? A lot of times we'll start doing cultures if we need to. Why are they more resistant?
They've been around a long time, would be my suspicion.
Exactly, right? The babies, they're the first ones that came about. Like, what did we do before antibiotics? Can you imagine?
Leeches.
What'd you say? Emily? Yeah, exactly. That was my answer. Emily, you and I are going to be great together, I swear. Leeches, right? Exactly. What is so cool about leeches, by the way? Do you know? I have an answer, of course. Who said leeches?
Me.
Okay, so what do you know about leeches? Why are they so cool, and why do they work?
Because they're bloodsuckers would be my only guess, but I got nothing for you. But
Okay.
they could mean, I don't know. I imagine they would probably work kind of like, I don't know, maybe not like maggots, but because they're suckers, they might draw blood to an area. Because I know they use it for like frostbite and stuff like that too.
Okay. Leeches are really cool, by the way, for medical management. And I know some practices actually have medical leeches that they grow or have. Emily, you're going to be a fan of leeches, I swear. I swear. They're so cool. Okay, anybody else know anything about leeches? This is so pharmacology, I swear.
Don't
Anybody
they
else?
release anticoagulants?
Yes. They also release a couple other things. Kristen, you're on to something. Who else? Anyone? Oh, come on, guys. Come on. They release pain relief. You're right. They have a little bit of analgesic property that they release. One more thing they release.
I'm gonna wait. Antibodies? There's no way they probably would.
What did you wait? Anti what?
Antibodies or anything like remove like toxins?
No, not antibodies, but antihistamines. No. Antibiotics.
Oh.
Antibiotic properties they release. Yes. So they're cool. They're super cool. So yeah, they can, you can put leeches on and they release all of those really cool things that are supernatural. Yes, they're disgusting. You put them on your body and whatever. But if you are in like, some kind of weird apocalypse and somebody stole all of the antibiotics, you need to go find yourself some leeches. That's it. So one holistic way of like treating an ear hematoma, truly, you could do is put some leeches on that ear and they just suck out that blood.
That's baller.
Do you still have to like suture it in place to make sure it doesn't fill back up with leeches?
You could try not doing that because sometimes they do that and it may work. It could always go back, and that you could still suture it. But I mean, there are so many ways of treating hematoma, an ear hematoma, but that is one to try. So
Interesting.
I know, isn't that so
Hey-
cool? I mean,
hey,
what
but-
category does that fill in pharmacology? So again, one of those things that won't be on the VTNE, but it should. In my VTNE, that would be. So like I know one specialty place where I live, they actually have like a tank of medical leeches. So I'm supposed to go there in a couple weeks. So
I was gonna say my specialty used them for an RCO start dog. It was weird. They fed on a big Great Dane too. The owner wanted to do multiple, so he had to do it over like, I think he had it like 3 times.
That's
Yeah,
pretty
it was
Oh,
cool.
honey, you shouldn't eat that.
Oh, okay. I won't. I know. I say that to myself all the time. I'm like, I shouldn't eat that, but I did. So, okay. So that's the holistic end of things, right? So back in the day, those are things that they had to do. Like, it's just mind-boggling to me, like how, you guys said, Emily said, they just died. They did. A lot of people died without antibiotics, right? Like, crazy. But they also use like other things they had, right? So we still do that. We still use things to that effect. We still use plant-like things, medicinal aspects of things for animals, for people, all of that stuff. And then we also have our modern day medicine too. So it's really good to know a little bit of that type of stuff as well. So you guys may work at a practice that does holistic end of the stuff if you don't already. So anyone do some holistic medicine?
We do.
A little bit? Yeah.
Well, our owner of our clinic is also I can't remember what the short is, but he does acupuncture. He went to school and did that in conjuncture. So he does dry needle, aquapuncture, laser acupuncture. We use laser therapies, Chinese herbs,
very good.
A lot of vitamin supplements, all of that stuff.
Yeah, absolutely. And if you think about it, the oldest medicine that's out there, right? The oldest one that you'll ever find is Chinese herbs and acupuncture.
Yep.
So something is working if that's still happening, right? And acupuncture is really cool because how does acupuncture work? I should start there. What do you guys know about acupuncture and why that works? Does anyone get acupuncture?
Isn't it like on a meridian scale? Like certain points? My doctor does traditional Chinese veterinary medicine and acupuncture and like
great. Yeah. So yes, you need to know the meridian scale and what point works where, right? So you can't just like poke your body in anywhere and then all of a sudden your pain goes away. You have to know, or pain, or it's not just pain even. It can be, helping your GI system, anxiety, like all different things, right? So one point, just so that you guys know, for anxiety or relief, just to make you guys, I guess anxiety, right, is right in your ear, right here. Is you guys can get like chia seeds that are on like a little, it kind of looks like a little Band-Aid, but it's like really tiny, but you can buy them. So it will help. So it's like right here on your ear right there. And you just put it on both in the inside of your ear. So before you take your test, you put that right there and you just kind of put it on there and it's like a little pressure point. So it's acupressure. And you put the little Band-Aid there. No one can see it, honestly, because it's just a little Band-Aid. And if you push on it when you're like feeling a little anxious about your test or whatever, or it's just sitting there, it's supposed to be a little help with relief of anxiety and stuff. So that might be something to think about if you wanted to help in that area.
I was just going to go get poked the day before I test.
Oh, good. See? Perfect. Absolutely. So I definitely agree with that too. Like if you're already doing acupuncture, that is perfect to go ahead and do. It's a chai seed. So typically they're made out of chai seed, but and they come like in a sheet, so you get a bunch of them. So even testing them out ahead of time to see like how it works and whatever. But yeah, it's just right on the inside of your ear. So I've done that before too. So it's really nice as well. So okay. Okay, so with acupuncture, we talked about meridian scale, so you guys know exactly where the points are. But how does it work? So they put the needle in that place where it's supposed to work. How does it work for pain? So
like they subsides because I got it throughout my whole month, like on pregnancy. And what she does every time she went into the point until like I felt like the pressure, and then little by little it just subsided.
yeah, so why does it subside?
I guess with like constant, like the point where she hits, it's how would I say, like she explained it to me, like you press something like kind of like a massage, you have to keep on like rolling, and then like it'll hurt in the beginning, and then the more you massage it, I guess the more pressure there is, like little will just release everything.
Yeah, so in your brain, right? So your brain can only handle one pain at a time, right? So it's called the gateway of pain. So when you take a needle and you're providing acute pain, like that's an acute pain by pressing on with that needle, right? And wherever pain that you had before, so whatever pain you had, if it's sciatic or whatever, right? Wherever she was relieving that pain, it was going through the gateway of that pain. So you have your initial pain, that chronic pain or whatnot. She was providing that acute pain, and your brain went, oh no, I'm getting two pains at once. That cannot happen. So it said, I will take that acute pain and get rid of that chronic pain that you have because I can only handle one at a time. So that acupuncture then point was working to get rid of the other pain. And because it was an acute pain, the acute pain doesn't last that long. So you just helped relieve that chronic pain, and the acute pain subsided as well. So she then removed that needle. And of course, your chronic pain is going to come back over time, right?
Mm-hmm.
And so you just go back and have your acupuncture then again to then tell your mind, oh gosh, here we go again. So it's really cool how it works, right? That you're basically telling your brain, we got to train our gateway again to like not have this pain. So I think it's so interesting how did they think about this, 2,000 years ago or whatever it was, but very good. So again, these are not things that are like pharmacology in our medicine wise, but these are things that we do now in practice to provide a type of medicine to our animals that relieve pain in so many different ways. Like cold laser that you guys do as well. And especially for acute pain versus chronic pain, like what are those differences that you guys see? Like what is chronic pain? What does chronic pain feel like?
Chronic is just like long term.
Yeah.
Like monthly pain. Like mine is like I have a lot of like back problems. I have arthritis on like on both my knees. But like right now it's like raining all week. So like you feel it.
Oh
constantly.
yeah, totally. And Juliana says it's aching dull pain, right? It's that like, oh, that horrible, like gross pain that we feel. Like can't even explain it because I have it too, right? And yeah, it's that arthritis, right? The constant pain that you have, right? Think about you guys too will know, right? Because you guys are working on your feet all day. And so it is that because you work on your feet all day, you come home and it's that constant pain from working on your feet all day that no one understands because we just work really hard. We really do. So that is that chronic pain that you feel, that achiness, and you just need to sit down and you just need a back rub because it's just horrible. Now, what is acute pain?
Sharp pain.
A sharp pain, right? It's like if I took a knife and cut something, right? It's when we do surgery on an animal and we cut them open. And so it's really sharp and it happens fast, right? And so it's completely different than that chronic pain. So we have to be able to manage that with many times different drugs. Like it's just going to work differently. We might not be able to do acupuncture on acute pain like we could with acupuncture on chronic pain. It just may not work appropriately. So we have to know what's going to work for animals a little bit better with acute versus chronic, right? So we might not be able to do rehab on acute pain where we can with chronic pain. Like, can you imagine if you just had a C-section and they're like, let's do rehab right now? You'd be like, no, that's not a good idea. Like rehab on a broken arm. No, that's not going to happen. So, but rehab on, a TPLO that's already healed, that's going to probably be a better idea. You're going to be able to stretch. You're going to be able to like move your leg a little bit better. That's going to be a little bit more effective for pain wise, right? And stuff. So, so if we're treating pain wise pharmacology, what would we do for acute pain?
NSAIDs.
Okay, so NSAIDs could be possible, right? But if it's really bad acute pain, what's going to be more effective?
Probably
Opioid?
Opioid.
An opioid, right? Yeah, definitely. Like, what are you going to want if you have some really bad acute pain? Right?
Morphine.
Yeah, I don't know that I'd want morphine. It makes you itch like crazy. I'd be like, skip that. Give me something good. So,
Opioid would work too.
Codone.
Yeah, so like hydromorphone, right? Or we have buprenorphine if it's not super crazy. So we have a lot of different things. So let me share my screen so we can start writing some down. So if we're talking opioids, what is our like mother of all opioids that we have? You guys already said.
Morphine.
Morphine. So it originates, that's our main one. So morphine's nice because it relieves quite a bit of pain, right? It's a great pain reliever. How many of you guys use morphine in practice right now?
Only when our specialist comes for TTAs and TPLOs and stuff. She'll use it, but we don't carry it ourselves.
Okay. And then how many, okay, so what are some good things about morphine? Like it's a good pain relief, right?
It acts pretty fast the moment it's injected IV.
Okay. Fast acting. Anything else good about it?
A little, I don't know if sedating's the right word.
Okay, so it has a little sedation.
Slows them down, I guess, post-op when we give it.
Okay, good.
Not expensive.
Good. Yeah, it's cheap. It is cheap.
And lasts like I guess for a few couple hours.
Good. So yeah, long lasting. Anything else?
It's reversible.
Ooh, good.
Oh, yeah. Naloxone, right?
Yeah, it's reversible. Very good. Yeah. Yeah, and you can give it with other pain relief. So very good. So yeah, we can give it with NSAIDs too, you know, we can give it with other combination drugs. So good with combos, right? We can give it as a CRI as well. So if you guys give like morphine, lidocaine, ketamine, CRIs, that kind of thing. So it's really good for stuff like that. Now let's talk about bad things about morphine.
Controlled.
Okay, yeah, it's controlled.
Like addicting.
Yeah. So what class is this or schedule is this?
Schedule 2.
Schedule 2. So yeah, it is. I hate my writing because I'm writing where the tablet's up here. Okay. So yeah, it's a class 2, schedule 2 drug. So that means we have to have a little bit more regulation on it on our end. So when you guys are writing in your logbooks, like your schedule 2 drugs have to be logged separately from your 3s, 4s, and 5s. So they just have to be you know, separated out. So you're right, they have an increased salivation, Jenna. So increased salivation, which then in respiratory depression, which decrease in respiratory, which in general, our opioids in general have a decrease in respiration. But
vomiting.
Yeah, good. I was just going to ask about the increase in salivation. Yeah, so vomiting happens. So back in the day, this was like when I first started as a technician, when I was in my teenage years, like 20 years ago. I remember we would use morphine as their pre-med, and we knew they were ready for surgery when they would vomit. And I was like, this is just awful. This is like the most awful reason to like know they were ready for surgery when they would vomit. Like there has to be a better way. So okay, Jude, perfect. Can't give it IV as it releases histamines. Yes, good. So shouldn't give, so don't give IV histamine release. So this is why I said I don't want to have morphine because I itch like crazy.
Oh.
I was given morphine once and I thought I was gonna rip my face off. Because yeah, you give a major histamine release. So many times instead, some of the doctors I've worked with give it sub-Q, which granted sub-Q, the bad thing about it is how you guys said it's fast acting if you give it IV, but if you give it sub-Q, it's slower acting, but it will last a little bit longer. So that's kind of the nice thing. And you won't have as much histamine release then because it is slower acting and it metabolizes a little bit slower. Awesome. I mean, you can also give it IM too. So anything else? This seems like a good start. So now that we know like the mother of our opioids, right? Then we kind of branch from there and say, okay, now we can look at all of our other morphines and say which one's the strongest, or I guess the weakest from morphine, and then go to the strongest. So probably one of our weakest opioids would be what?
Butorphanol.
Okay, so butorphanol. And probably before that would be like Tramadol.
Yeah.
But we can kind of skip him for now. Because he's only a PO drug. And many of you guys probably don't use Tramadol as much as we used to. We used to give it out like candy. So, but a lot of our doctors are like, this doesn't work quite as much as we thought it did. So that one is not our fan. So, but what class though is Tramadol?
3? Oh wait, no.
5.
Good. So yeah, Tramadol is a Schedule 5 or class 5. So that means that how abusive, or how much can we have abused, I guess, Tramadol?
Is it a 5 or a 4? Tramadol.
I think it's a 5.
Okay.
And I should say that we're doing scheduled drugs in the United States. So if any of you guys are in Canada, it's going to be a little different. Oh, I lie. They have moved it into a Schedule 4.
Thank you.
Yeah. I lie.
That's what you wrote anyways.
And I just wrote 4 instead of 5 anyway. So I don't know what I must be really tired today. And then there are some states now that have gabapentin, by the way, in a schedule as well as a Schedule 5. Most states don't have gabapentin yet as a controlled drug, just FYI. So that is one to double check in your state, just to give you a heads up. I want to say that Georgia, it's one of the southern states. Georgia just made it a scheduled drug, but most states don't have it yet as a scheduled.
I haven't yet, and I live in Georgia.
Okay, I have to double check. One of the southern states just made it scheduled. Now, also gabapentin, though, its sister drug, which is Lyrica, is scheduled too. So, but we don't use Lyrica too much. I've only been at one class, or one practice that used Lyrica, and it was scheduled. Oh, here it is. I lied. It's Kentucky, Michigan, and Tennessee. So if any of you guys live there, it is a Schedule 5 drug.
Does it say when it came into effect? I'm in Tennessee. Like we haven't heard anything about it. I have to ask one of the doctors tomorrow.
It went It doesn't. This is like pretty recent because 2019, July 19th, 2019. That's when pregabalin became like class 5. So it had to have been somewhere after that. So this must have been fairly recent. And I remember hearing about it literally like within the new year. Yeah, it looks like sorry, I'm just kind of trying to find the I can put it in on our Facebook page if that helps. You said Tennessee?
Mm-hmm.
I have the Kentucky one here. I'll find it. I'll put it in our Facebook page of that school.
Okay.
So that way you can see it. Yeah, it looks like Virginia maybe too. I know from like my job, my other full-time job, I have like 5 states that I cover, but all of my other people, they cover all of the states too. But this is something that we're watching too for everybody, because this one has been on the fence for like such a long time. And then as you guys know too, like Proen has been on the fence for a long time. And yeah, I mean, it's good to kind of just keep your guys' eye on it too, of like if it's going to be controlled. So whether or not you guys put it in your lockbox, or just have like a locked cabinet to have those guys as well in there. But I'll put it in our Facebook page for you guys so you can see it. I'll make a note so I don't forget, because I forget a lot of things. Okay, so going back to this. So butorphanol, what are some really positive things about butorphanol?
It's a good additive with other drugs like Kitty Magic, and we use it in dogs. We'll use Torb a lot with Dextom. I'm not going to say it right. Dextometer.
Okay. Good. So you were talking about Kitty Magic, right? So I was going to ask, what is Kitty Magic? And then we had, there's Kitty Magic. We have everybody use a bunch of different combination, right? So essentially how we use it is dexmedetomidine. Some people use ketamine, and also butorphanol.
Or we'll use buprenorphine sometimes with it.
Buprenorphine. Okay, perfect. So yeah, depending on pain level, right? So pretty much our Kitty Magic would be an alpha-2 agonist. Then you have whether it's ketamine or tilazol, you essentially are using you are going to use, what is ketamine or teledamine? What are those drugs called? They have a couple different names. Ketamine. Yes. Good, dissociatives, or they're also called other things. Dissociative. They have 3 technical names. Cyclone, right? Cyclone something.
NMDA.
NMDA, very good. Cyclohexamine, right? That's the other one. Very good. So you have your alpha-2. So you have an alpha-2. You have your dissociative. And the last one that you're going to have is some sort of opioid. So that's your Kitty Magic. So that's where it gets a little confusing, because your doctors are going to pick like whatever they want to put in a Kitty Magic things. So people, you know, in general, they just remember like, oh, you know, it's DKT or whatever, and they just know like their doctor's little special. But truly what Kitty Magic is a combination of these guys. So just understanding that, okay, our doctors can change it up if they want to, but this is really what it is. So kind of keep that in mind of like, we have drug classes, and those are our drug classes that we can use. So even if you wanted to, you pick your alpha-2 dissociative and your opioid, you know, we could use, like you said, buprenorphine. You can use Hydra if you really wanted to. You could use morphine if you really wanted to. So you just pick what you like. If you don't like xylazine, you know, if you don't like, you know, you can use xylazine, you can use dexmedetomidine, whatever you want to do. So just kind of keep that in your pocket. Let me get rid of this. Okay, so butorphanol is good as Kitty Magic. It's our little Kitty Magic treat. So Kitty Magic. Great. Cough suppressant. Good. So it's fast acting. It's an antitussive, so that kind of goes with this.
Partial reversal for other opioids.
Yes, good. So partial reversal. My writing is just awful, so I'm sorry. Good. So what is that called when we say partial reversal? So if you see the word, it would be what? It would be agonist.
Antagonist.
Oh God, that's right, better. Antagonist. So that means agonist means I'm going to sleep. Right? So agonist is like that 15-year-old kid who wants to sleep in on a Saturday morning until 12 o'clock, right? And antagonist means I am the 5-year-old little brother or sister who wants to wake up the agonist because it's antagonizing them, right? So waking up. Does that make sense? So naloxone would be what? What is that? Yeah, it's an antagonist, right? So that is the waking up. Naloxone is literally just a 5-year-old little butt that is like, nope, I'm going to be a jerk and wake you all up because I don't care. So if you look at it that way. Because these words I know sometimes make everyone's mind go nuts. And they're like, I don't get it. I don't get it. Okay, so anything else about butorphanol that is super, super cool that you guys really like about it?
A short acting.
Okay, yeah, that can be a really good thing, right? Short acting.
Like short acting, I guess, pain control.
Okay. Is that a good thing?
Not really.
Oh, okay. So we might want to leave that off. All right. Okay, so what else do we like about it? Anything else?
Multimodal.
Okay, we can use it for multimodal, right? Anything else? It's good for sedation, I guess. Because we use butorphanol a lot in cats that come in for breathing issues, right? And not necessarily just for like because it could just be that they're having trouble breathing. but we're not necessarily using it for like antitussive issues or that kind of thing, because it might not be the fact that they have fluid or anything like that, but we use it for a sedative effect, because just think about the fact that you can't breathe. You're freaking out, right? So we give them a little bit of butorphanol, because butorphanol is not super sedative effect. Like if we gave them morphine, that just might do them in, and we don't want to do
Like
that.
pretty much like smoothing their, like the coughing, I guess, to be a little bit easier kind of controlled, so they're not constantly just like hacking and then making it worse for them.
Right. But if, let's say they're not coming in for a hacking issue, say they're coming in because they can't breathe, and we don't know why, right? We want to give them something just to kind of make them relax, you know, because they're freaking out because they can't breathe. Like say you come in and you're just freaking out because you can't breathe. We want to give them something just to calm them down so that they can try to catch their breath, right? So we can put them in oxygen at least to get them to breathe, because maybe they're oxygen dependent, but we want to make sure that they can actually stop freaking out. We want, you know, it's not necessarily for the opioid effect, because as we know, we're going to talk about the bad thing about opioid, about pain relief. It doesn't provide a lot of pain relief and for a long period of time, but we want to give them something sedative, right? So we give them a little bit of butorphanol, because it's going to decrease a little bit of that anxiety and fear that they can't breathe at that period of time. I mean, I guess it's not going to give the anxiety, but it's going to sedate them a little bit and just a little bit of relax. So yeah, maybe not anxiety, because again, anxiety is a little bit different, because we think on that level, anxiety, sedation decreases anxiety, but it doesn't. It just looks like it does, right? If we gave them Benadryl, does that decrease their anxiety?
No, it causes mild sedation.
It just gives sedation, right? So a better way of decreasing anxiety in animals is to give them gabapentin or trazodone, stuff like that, right? So we've learned that over time, and people are still learning that. Before, we used to just do like acepromazine or Benadryl, and really what happened is that it made us feel better because they were sedated, but really in their mind, they were still having anxiety. So very good.
Doesn't it have like an antiemetic purpose too?
What's its antiemetic purpose? I don't know. Not that I'm aware of, but I have to look, honestly. I know that, what is it called? Antiemetic purpose would be technically an acepromazine, but I don't know that butorphanol does. So yeah, I have to look that up actually. So what are some negative things about butorphanol?
Limited pain control.
Okay, good. Limited pain control. So how long does butorphanol last?
Couple hours.
Ooh.
So like 2 to 3 hours?
No.
Like 30, 40 minutes?
Yes. Yes. So 30 to 40 minutes. Very good. Like nothing at all. Isn't that crazy? So
that makes sense on why it's used in Kitty Magic and stuff then, because they wear it off fast.
Okay, yes. So then what do we do afterwards for pain control then in Kitty Magic? If we just give them butorphanol, how do we do pain control?
We usually use Buprenorphine when we do cats, because we use Kitty Magic for cat spays and then we ISO them. So we'll usually substitute Buprenorphine instead.
Okay. Perfect.
So they have a longer pain management. And a lot of them, if they're old enough, we give like an Onciora ahead of time or something to help.
Great, great. So if you are using butorphanol instead, so here's the scenario. If you are using butorphanol instead, and you say are doing kitty magic, how long ahead of time would you have to give your Oncior to make sure that the Oncior kicks in before the butorphanol runs out?
We usually do it an hour or so before surgery.
Okay.
Do we need
So
more?
how long does it take for Oncior to kick in? So an hour before surgery, and then so it's an hour before surgery, and then you give the butorphanol right at surgery start time. So you're close. You're about.
Does it take a couple hours?
It takes 2 hours
Okay.
for any NSAID to take full effect.
Okay.
Yeah. So you guys are very close, very, very close.
Okay.
If you're using butorphanol, okay?
Yeah.
So yeah. And so it doesn't matter if you give if your NSAIDs are given injectable or if you give it orally. They all take, it's called the Tmax. The Tmax is the essentially like how affect your it looks like this, where your NSAID or any drug that you give, how it is metabolized, right? So it starts hitting the level of right here where it's at the highest point of reaching full effect. So here it would be that 2 hour mark for your NSAID. So
I'm sorry, that includes all NSAIDs?
Oral NSAIDs and then also injectable.
Okay.
Yeah, they all take the same time to reach. Isn't that crazy? And I should say, I didn't look up if you did NSAIDs injectable like IV, because I know that in the US we don't do that. So in Canada, they may do it, but I know in like Europe, they give like Rimadyl and stuff like that IV because it's approved, but it's not.
I'm sorry.
Yeah.
In Plum, I thought that I had read that you can do one dose, like the first dose of meloxicam, you can do IV.
Our label says you can do Ostilex IV.
You're correct. Meloxicam is different. I guess I'm talking about like Rimadyl. I forgot about meloxicam.
Okay.
Yeah. No, you're correct about that. Meloxicam you do IV. I like carprofen and Oncior and stuff. We don't do IV here, but I know that in Europe and stuff, they do carprofen and stuff also IV, which is approved there, but is not approved in the States yet. So I can't even think about doing that IV because it just seems so weird, but you're right. Yes, thank you for bringing that up with meloxicam. We do also do meloxicam here IV for the first dose. And
where's my other one?
Okay, so good. Butorphanol. So kind of remember that with butorphanol, if you're going to do butorphanol and then do your NSAID ahead of surgery, just try to give your NSAID just a little bit more ahead of time so that it kicks in, afterwards, like after your surgery or like throughout your surgery. And then you have good pain relief. Or just give another dose of Torb, like post-surgery as well, so one or the other. So anything else that's negative about Torb? I mean, this is a big one that people don't realize. So
Isn't it contraindicated in some breeds? Isn't, I heard there was like something with the genetic makeup of some breeds that, like if they had some
I think an MDR1.
MDR1 in some, my doctor had one and she said that it was contraindicated in this breed for genetic mutation or something.
I don't know what I fucking did.
I know that's in acepromazine. I can look at my plum really quick. I'm not thinking in Torb that that's a thing. I've not heard of that.
It's good. Do you want to try it? I'll just take it for now.
Yeah, we can't do that in ACE. Torb, I have not heard of, and buprenorphine, I've not heard of that. Oh, you are correct. It is, so you can give it to MDR1 dogs, but they just recommend reducing the dose by 25%.
Okay.
Very good. So you said that your doctor's dog is an MDR1 mutant. I call them mutants.
Client. So we get all the oddballs because we do a lot of the Chinese therapy stuff.
Yeah,
we get those.
Interesting.
And there was one dog, I can't remember, it was like a sheep hound or something like that had this weird mutation. I'm like, how did you ever think about getting that tested? I'm just curious. But they had to go to all these it's like a mutation. It's a genetic mutation. They had to go to neuro at UGA teaching hospital.
Yeah. So our MDR, thank you for asking that, Nicole. So MDR1 is a mutation that certain breed dogs, you're right, have. And essentially what happens is, and this is kind of interesting, so, and we'll talk about the breeds itself too. So what happens is that they can't metabolize certain drugs appropriately. And so essentially the drugs can't cross the blood-brain barrier correctly. So when we have drugs that we're metabolizing or other animals are metabolizing, they go from the blood to the brain and then can metabolize out of the brain. But our little MDR1 mutants, as I call them, unfortunately aren't able to cross that blood-brain barrier correctly. So they go to the brain, but then they can't come out. And so there's certain drugs that they can't do that for. So there's a lot of them. There's like a huge list of them.
Big one.
What I will try to do is find a list of drugs for you guys for MDR1s. So I can share with you. There's a ton, honestly. So it all kind of started with finding certain ones, like acepromazine is one, metronidazole is a huge one. And so we see like metronidazole toxicity, and it's really, really sad. I've seen a metronidazole toxicity that went really bad in a puppy that was a Sheltie. And it took a really, really long time. We thought that the puppy was going to die, but luckily we saved him. I have not seen with buprenorphine, honestly, so I appreciate you bringing that up so I could look it up. This is what I really love about having these with you guys, because I honestly learned so much from you guys and your experiences too. So this is great. So what what are some of these dogs? Like what types of dogs do we see this in?
Herding breeds.
Yeah, herding breeds, right? Collies. So anything that looks like a collie, right? And herding breeds. So, yes, metronidazole can make them vestibular, neurologic, all of that. So it starts with being vestibular, and then it becomes worse and worse from there until they are in a coma, essentially. So that's what happened with that one puppy is they were vestibular, then they basically went into a coma, and then it's like reversal from there. So luckily, he did get better, but it took a really, really, really long time. So,
Diazepam for treatment, or did I get that? I'm not sure.
I think we did. I honestly forgot like the whole bit of it. We had to do, yes, diazepam for seizure control. And then we also, I remember had to do also methocarbamol at 1.2, but I can't remember essentially like all of the treatment that we had to do. A lot of it was supportive care, to be honest, but it was pretty crazy to watch that whole process. So, so I have a border collie. I had 2 previously and they got old and ended up dying in the last few years. And then I now have a 7-month-old border collie who's very crazy. You guys will see one of the videos when we start talking about behavior of one of my border collies before, but that is one thing that I am testing for is MDR1 mutation, because again, it's really important that we know what we're dealing with ahead of time, right? So that we don't get into this issue of what drugs can we give. What is another drug that we should be cautious with, really cautious with our MDR1 mutations too? Oh, you knew it, Juliana, you knew it. I was like, oh yeah, this one is like a big one. Ivermectin, very good. So especially when we're talking about this question comes up all the time when you're in practice with our colleague people. And so one of our heartworm drugs has ivermectin in it, right? Oh, and the Morales had it too, sorry. Oh, HeartGuard. Yeah.
HeartGuard.
Yeah. So this question comes up all the time when people come in for heartworm treatment or heartworm prevention, right? And then they see HeartGuard and they're like, oh my gosh, I can't do that one because it has ivermectin in it. But can collies get HeartGuard? Or, herding dogs in general, get HeartGuard?
A few of our clients use it. They just gave it a crack and hoped for the best, and they've done fine.
Yeah. So yes, they actually can use it. It's very low dose of ivermectin in there. So it is safe enough for them to be able to use it. Obviously, if they're really concerned and they don't want to use HeartGuard Plus, there are a ton of different options now out there for them to use heartworm prevention, so it's not like it was before where we really did only have HeartGuard, so they can choose a ton of different options for them. So got way off topic in that sense, but great. I'm so glad you brought that one up for butorphanol because I did not know that. So thank you for teaching me that. Anything else then for butorphanol? Butorphanol is kind of boring. It's not super exciting to me.
You had another big one. I don't think you actually touched on it. We got distracted by the MDR1. You said there was one big thing about butorphanol.
Oh, I think that was the one of the limited pain control.
Oh, okay. Just making sure.
Yeah. Thank you. So perfect. Okay. So after butorphanol, what is our next one that we utilize? That is probably more potent than morphine.
Buprenorphine.
Buprenorphine, very good. I love buprenorphine for pets. I love it. So Let's talk about the good things about buprenorphine first. I don't like the negative stuff. I don't like to be all negative. So what are the good things first?
Used for moderate pain control.
Good, moderate pain control.
Good bioavailability in cats.
Bioavailability in cats.
You can use it orally in cats, which
Or
is nice.
orally, yeah.
Okay. Orally. I'll put transmucosally.
Transmucosally, yeah.
Just to be like correct. I mean, additionally correct. I don't know. Whatever. Oh, I forgot a U, but whatever. I give up on today's writing. Okay, and then I forgot. Buprenorphine is a class what drug?
3.
4.
Class 4. I mean, think about buprenorphine. Like, how much do you want to abuse that? It's only going to last for 30 to 40 minutes, right? Not that exciting. Okay, so transmucosal in cats. What else is really great about buprenorphine? No vomiting.
Long lasting.
No vomiting. What did you say?
Long lasting.
Long lasting. Yeah. How long does it last?
About 8 to 12 hours.
Maybe not
8 hours.
6 to 8.
Yeah. So, yeah, about 6 to 8 hours. That's pretty nice. Pretty nice. And anything else? How about the negatives then? We can always add more positives out that come along.
It's one of the few that can't be reversed.
Good. Can't be reversed. Why can't it be reversed?
It's an antagonist for other opioids.
Is it a partial agonist?
Yeah. Well, it's a partial. It's just like
Antagonist? No.
Yes. So this guy as well is an agonist, antagonist. Ugh. Just like butorphanol, right? So the little story that goes with it is buprenorphine was brought into effect to help with people who were addicted to opioids. And so it was given so that they could take buprenorphine to help relieve their addictions, right? But of course, it helps with pain relief. So we also now use it to help more or less with pain. So essentially, I find many times that we have animals who have surgery and we put fentanyl patches on them. And fentanyl patches take some time to take effect, right? Like they don't just automatically work right away. So how long does it take for a fentanyl patch to reach full effect?
12 hours.
12 hours, right? So you put a fentanyl patch on and it takes 12 hours to take effect. So in the meantime, people are giving buprenorphine until the fentanyl patch kicks in. But what happens is that we have our staff continue to give buprenorphine the next morning and not realizing that, hey, the fentanyl patch has now kicked in. And so what they're doing is that fentanyl patch is working and they're giving buprenorphine. So it's reversing the fentanyl. So it's like, oh, guys, we need to stop our buprenorphine. So again, it's that understanding of these drugs. You know, sometimes the doctor forgets to, you know, you have your buprenorphine box and they forget to come back and go, stop giving it. So it's our job as technicians to go from our nursing and go and check with the doctor and say, hey, you left this box here, but our fentanyl patch has been on for 12 hours. Are you sure you want to still give the buprenorphine? And then they go, thank you so much. You're like the smartest person in the world. Yeah, you can discontinue the buprenorphine. Right? So that's why they need us. It's to double check things. So very good. It happens a lot, like a lot. All right. So what else is bad about buprenorphine?
Cause respiratory depression.
Okay. So again, we got bad respiratory depression or respiratory. Decreased respiratory, right? All of these, of course, do, but they get worse as we go down, right? What else? Who likes drawing up buprenorphine?
The little 1 ml vials, and then you have a giant dog, and you have to use 5 of them.
Yeah. The packaging is awful, right? So packaging. Terrible. What is also nice about buprenorphine now that they have created, there's a different type of buprenorphine, right? Anybody use it?
The extended release?
Yeah.
Okay.
So SR. So what's good about SR versus bad? So SR is good for, long lasting. It lasts 3 days, right? Which is great because then you don't have to like send home 20,000 syringes. Oh, it stings, right? So SR stings. That's not good. Anything else?
You can compound it if you need to.
Okay. Compounding.
Mostly cats, I feel like.
Yeah.
They're the culprit for everything.
It has to be refrigerated. Which, okay, so it has to be refrigerated, right? So that's a bad thing. So why is it a bad thing because it has to be refrigerated?
Because then you need a lockbox in the refrigerator.
Yeah. So you need a lockbox in your refrigerator. And so what do you have to do with that lockbox? You just put a lockbox in there, right? And you set it on the shelf in there, and that's it, right?
It's got to be tied down. It has to be secure.
Yeah, it has to be bolted down. How annoying, right? It just has to be secure in your lockbox. So even if you get a little lockbox and you Gorilla Glue it in there, you're good. As long as it's secure in your fridge, you're good, right? Perfect. Great. What else about buprenorphine? Anything? How do you guys send home transmucosal buprenorphine?
Individual syringes.
Individual syringes. Good. Do you guys label those individual syringes, like just by writing that they're all buprenorphine?
Or one doctor will print 20 labels and wrap each syringe with a label.
Wow. Fancy.
Mhm.
And then what do you do with those syringes? Where do you put them? Do you put caps on them?
Mhm.
Great.
Usually tall pill vials, we can usually fit them in, so we can put a label on that too.
Beautiful. Yes, they can be light sensitive, absolutely. So depending on what you have. So that's good to check in your like in your insert to see if they're light sensitive. Very good. So you're right. So you're putting them in a pill vial. Why can't you put them in a bag? Just like a regular bag?
Not childproof.
Right, right. So we say child resistant because nothing's childproof, right? They're usually birth proof, but that has to be child resistant, but you're right. So you can get child resistant bags if you really have to have a bag. They're just more expensive than, you know, putting it in a one tall dram vial. It's usually like a 90 dram vial that you get, but very good. I'm so proud of all of you guys for doing that. Because we still see a lot of bags out there that people do and we're like, no, don't do that anymore. Very good. Awesome. And then what class is buprenorphine in?
3.
3, good, because it is definitely a little bit more, you know, utilized than butorphanol, right? It's more, we definitely see it abused a little bit more. So these guys, very good. So we then go from buprenorphine to which next opioid?
Hydromorphone.
Hydro, very good. So most of you guys will have at least butorphanol and buprenorphine in your practice, yes?
Yes.
At least? Okay, good. Some of you may have morphine. Many don't have morphine anymore in their practice, and many just have like butorphanol, buprenorphine, and then go to hydro, which is great. I love that. Some people may have morphine because if they have like a orthopedic person come in, they'll like make a morphine CRI. Or I mean, you can even make a hydro CRI too if you really wanted to, but great. So hydromorphone.
Is methadone there too? Like,
so yeah, we have methadone that we can chat about too. So I would say methadone we'll talk about after hydro. And the only reason for that is because methadone, I would say, is a little bit more expensive, number one. And I think they're equal in probably, well, they're probably equal in pain control, but methadone I think is higher class. So, yeah.
Less side effects.
Exactly. It totally is. And I love it. I truly do love it. So yeah, we'll chat about methadone. I would say not on your VTNE, but really good to know about and to push for, honestly, to like higher standard of care for sure. So if you guys are already using methadone in practice, good for you. Good job. So, and so yeah, if you're using it, let's chat about it. Okay, so hydromorphone, what class is hydro?
It's a 2?
It is a 2. This one is totally abused a lot. And so if they're a class 2, what do we do different about these drugs when we are logging them, stuff like that?
Their own log.
Yeah, they have to have their own log, right? So, and the reason for that is, say the DEA comes in, they want to see your class, well, if you had class 1 drugs, which you're not going to, but class 2 drugs, they want to see those guys first, your logs for that. So you're going to show them your class 2 drugs. And if you had your class 2, 3s, 4s, and 5s together, they're going to look at all of those first. So you want to just show them your class 2 drugs first, so that they can just see those and then be done with the day. If they see something wrong with your class 2 drugs, then they're going to want to see your 3s, 4s, and 5s. So you want the DEA people in and out of your practice ASAP and not spending all day there. So it's easier to just give them, you know, one class at a time than everything at once. So just give them what they're asking for. So, and these guys need to be like top notch because they're the most abused that you're going to have in practice. So, okay. So Hydromorphone, what are the good things about Hydro?
Great pain control.
Yeah, they're good pain control. So it's for moderate pain, moderate to severe pain, right? And what else?
Isn't it a new agonist?
Yeah. So we're hitting like our awesome receptor, right?
It's 10 times more potent than morphine.
That's great. Yeah. So 10 times more potent. Very good.
It decreases GI motility.
Okay. So we would probably put that in our negatives, right? Which all of our opioids are going to decrease GI motility, right? So what's really good to know too is that, and you'll hear this all the time, that owners call you like the next day and they'll say, my dog hasn't had a bowel movement yet. I'm really concerned, right? Emily's like smiling. So that means that she hears this once in a while, maybe twice. So what's the reason though? It's not just from the opioid. What else decreases GI motility? That just happened after a surgery, right? Like anesthetic, right? Your gas anesthetic also decreases GI motility. The fact that they were NPO also doesn't help, right? So all of their drugs in general have decreased that GI motility. And then think of the PO meds that they went home with too. Are they going to make them be constipated? Like, did they go home with like Tramadol even? That can cause constipation too. So making sure that you know like the side effects of these drugs and the positive and negatives about these drugs are really important so that you can just tell them like, this is the reason why. Make sure that you're feeding them, you know, a high amount of water to keep them hydrated so that they're not getting constipated, potentially changing their diet too so that, you know, they are getting fiber in their diet so they aren't getting constipated, that type of thing as well. So if any of you guys ever had surgery before and stuff as well, that's a huge thing that they talk about too, because of the drugs that you're on, because of the anesthetic you're on, that your GI system does slow down quite a bit. So, let's see. What else do we know about Hydromorphone?
Increased panting.
Yes, very good. So, if we have animals who get hydro and they start panting, this happens all the time. What animals should we not give hydro for, especially if we're working in emergency cases?
Brachiocephalics.
Good. That could be,
Yes.
yeah, but there's,
Sorry.
go ahead.
Chest trauma.
Oh, wait, what'd you say? Heart?
Chest trauma.
Oh, chest trauma. Very good. Very, very good. Yeah. So why wouldn't we want to give, what does it matter with chest trauma? I mean, say you went to the hospital and you had chest trauma and they gave you hydro.
Oh, I suppose if it was a hit by a car or something, there might not be as much room to expand, or if there's broken ribs or.
Exactly. So why is that going to matter? Like, how would you feel if you had chest trauma? Like, you were just hit by a car, right? You personally were just hit by a car and they gave you hydro and you started panting, which sounds really weird, but you started panting.
Then you pant.
Yeah. Like, I know people don't pant, but like, but how would that feel if you just had chest trauma?
Not good.
Right. You're kind of working against your drugs, right? So probably not the best idea. So we should probably pick another pain medication. So knowing, again, the negatives and positives for each drug is important before picking the drug of choice. So, so instead for those guys, what drug would we probably pick?
Methadone.
I love it. Methadone, right? Okay, so if you had methadone, but if you didn't have methadone, right, you could pick buprenorphine because it's going to last long. Fentanyl, yes, you could pick, but fentanyl doesn't work as long, so you have to do a CRI. So yeah, like you have to pick something different. So very good. Anything else about hydro that we need to know about?
Does it raise the temperature?
Yeah, so good. So opioids in general have an effect on your temperature release in your brain, right? So the temperature control. So you will see this a lot in animals where their temperature control is out of whack. And so, especially in cats, you'll notice it where their temperature will increase due to opioids. Okay, so they could have a high temperature just because of having an opioid. And oh, okay, bye, Emily. Sorry. Yeah, we're just going over because I was super late. So, but don't y'all worry. So yeah, it's nothing to be super concerned with unless it's super, super high. And of course, with hydro, you can always reverse it, right? If you had to. And so what I hate the most is when people just take all of their bedding out of the cage because they have a fever. That's not going to fix the temperature, right, of the animal. Sure, you can put like, you put them on fluids if they're not already on fluids, like try to get their temperature down. But now you're just making them uncomfortable, right, by taking everything out of their cage.
Could
So
you use a pie, I don't remember the drug name. It's pie something to reduce fever.
I
remember what it's called.
Pie. So you can give them meloxicam, which helps reduce fever. So that's one thing you can do. I'm trying to think what you're talking about. I have to think about it. But yeah, meloxicam will help in reducing fever, especially in cats. But in this case, it's not necessary. It's just the temperature control. So once the hydro wears off, then their temperature will come down. So, and then of course, you can always pick a different drug once it wears off. Or if you're really, really concerned, again, you can reverse it. So, but yes, very good, Jude, on that. So, temp control. All right, so let's go to methadone really quick because someone is in love with it. All right. So let's talk about pluses.
Less side effects than hydro.
Good. So less side effects. Great. So what else?
Good pain control.
Very good. Yeah, good pain control. So good pain control. And this is for moderate to severe. Oh, very good. What else? And you can use this for like bolus pain control, like injectable, or you can also use methadone as a CRI too, which we've used a lot, you know, which that's what I love. What else?
Sorry to interrupt. I figured it out. It's dipyrone.
Oh, dipyrone. Okay. Okay.
Yep.
Perfect.
It's
I'm like,
50% there.
okay. No, that's great. I'm like P.
Yeah.
Great. Great. What else with methadone do we know about? What's some negatives about methadone?
Expensive.
It is very expensive. Oops.
Other than that, no other negatives.
Yeah, it's expensive. Yeah, so we were actually going to use methadone in when I was teaching in our animals that came from the shelter, because we just loved, we would just love like utilizing it so much more, and we felt more comfortable having it rather than hydro. But because it was so expensive and the budget for schools is really, really small, we couldn't. So I was very sad. But so what about respiratory center and stuff like that? Is there respiratory depression in methadone?
Yes.
Yes. So we still have that respiratory depression, right? Can you still see like bradycardia and stuff like that in methadone like we see in other opioids?
Yes.
All right. How about histamine release?
No.
Okay, so we can still see some histamine release, but it is not as much as some of the other ones for sure. But yes, you're right. It's very little amount. How about transmucosal methadone?
I don't know that we've used it that way.
Okay. So I guess you can use transmucosal methadone. It's just absorbed slower than like buprenorphine. So I have not seen it done transmucosally either. Now in horses though, you can use PO methadone, and it's actually absorbed really well. But I don't work with horses, so I can't really tell you. And then it says in goats, you can also use it sub-Q, and its bioavailability is really great. So it's kind of interesting.
Was that IM with goats?
Sorry, sub-Q.
Oh, sub-Q.
Yeah. Half-life on that is 3.6 hours. So it means that it lasts pretty long then, in goats. So that's kind of cool. Like 7 hours total. So yeah, like goats and horses. Cats, you can do transmucosally as well, just absorbs slower. Looks like And it doesn't last as long. So yeah, it doesn't last quite as long as like buprenorphine. Interesting. I guess if you have something really painful, that you could do it transmucosally, or rather than buprenorphine, you know, that's kind of. All right. So what class is it? Thank you for asking that. That was my next thing. So what class is it? What class would you think it is? Because it's like a really big drug, right? Like who's gonna take it? It's a 2. Very good. Very, very good. Awesome. All right. So what's our last drug that we really focus on in our opioid section?
Fentanyl.
Fentanyl, yeah. This is our big, big drug that we work on. So fentanyl is what class as well?
2. That's a 2 as well.
2. 2, good. So fentanyl, one really cool thing about this, so methadone's really expensive, right? Hydro is kind of, it's not as expensive as methadone, but it can be expensive at certain times. Like it depends on the availability of hydro, I guess I'd say. Fentanyl, on the other hand, is cheap. Except for when it wasn't available at one point, but it's pretty cheap. So that's the nice part about it. So that's why we can use it for like CRIs a lot of times and stuff like that. So it's not like something that we ever worry about utilizing a lot. So that's a really great thing, is that it's great pain control. It's for like severe pain. It's great pain control. It's pretty cheap. We have so many different ways that we can give it, right? We have like our bolus that we do. We have a CRI that we do. We have fentanyl patches. So there's like a lot of cool ways that we have it and can give it. In humans, they have even more ways they can give it, like they have suckers and stuff like that. But we don't do that for pets, so for obvious reasons. So what are some other things that you guys know about fentanyl? How strong is fentanyl compared to morphine?
150 times.
Okay. So typically we say it is 100 to 250 times stronger than morphine. And the reason we say that is that in the medical aspect, it's somewhere around here in the like what we get. But this is where it becomes dangerous, that we see fentanyl on like the street, right? You see it more like this. So now you guys know why it's super dangerous, right? That it can be super variable if it's not regulated appropriately, because fentanyl's super strong to begin with, and then it's made even stronger and stronger and stronger. So we get something more regulated and it's really strong. It's really strong here. But if you see something on the street that's this strong, now we know why people are getting hurt. So hopefully you don't see that. So yes, it's super, super strong. And so what are some good things again about fentanyl that we like?
Also less side effects than hydro.
Less side effects than hydro, right? Like we don't have panting. No panting. less side effects than hydro. Anyone ever hear of, oh, this acronym?
Yes.
What is that?
Total intravenous anesthesia.
Intravenous. I'll put that. Venus. Oh my gosh. I can't write. Anesthesia. Good job, Beth. Good job. Okay. So yeah, total intravenous anesthesia. So what does that mean though? If you're doing surgery, what does that mean?
No gas.
No gas, yes. So you are not using any SIVO or isoflurane or anything. So what are you going to give?
CRIs.
Yeah, some sort of CRI, right? And so these are so fun to do, by the way. Like I literally love doing these. But I have done this with literally only fentanyl. And it's so cool. I've also done it with fentanyl and some propofol before, or a combination of fentanyl, propofol, and diazepam. And they're so smooth. Like they just run very smooth through their procedure, compared to your gas anesthetic. We still put them on oxygen, right? We still want to oxygenate our patients. That's important. But there's no ISO or no ISO or sevoflurane. So under 45 minutes. Yeah. So yeah, you want to still do your procedure. Like, we always want to do our procedures quickly, right? We want to get it in and out. But essentially what you're doing is multimodal, right? Anesthesia. And with anesthesia, our protocols, we always want to have anesthesia, and with anesthesia, it's always analgesia too, like analgesia. So you have to have both, right? Because we can't just cut our patient with anesthesia because they're just sleeping here, right? They're just asleep. And that's not cool because they're still going to feel stuff. So we have to have pain relief as well. So if we have that balance, then they're awesome. So the nice thing about it is you can pick from any of these. Fentanyl is just nice because there's a great range of fentanyl, and fentanyl, again, is really potent. So it can make them sleep really nicely a lot of times on just fentanyl. You can also do methadone. You could do hydromorphine CRI with your anesthesia, and it really makes a huge difference. So the nice thing about it is understanding, again, all of this great information, you can have great choices and not just think, okay, I can only ever do kitty magic and gas anesthesia, or, but there's more great options, and tailor it to a patient. Every patient's going to be different. And so you have to tailor it to their needs. So you may have an animal who it won't be able to handle gas anesthesia appropriately. So it's important to know, like, there's different options, and never have it in your head that, well, that animal's too old, I won't be able to do anesthesia on it. That's not true. So what are some bad things about fentanyl?
short acting unless you use a CRI.
Right. Yes. Yeah. So it's short acting, right? So that's why we have to use a CRI. Yes, Janelle. So yeah, we're just finishing up right now. So our next meeting is next Sunday at 1:30. I will definitely be on time. So but thank you. We're just gonna finish up fentanyl and then I will have to actually go too. So but thank you so much for joining today. Yes. And then awesome. So the biggest thing with fentanyl is that it's short acting. So very good. And then we talked about naloxone is our reversal, our main reversal for these drugs, right? So yeah, these again, all of my chicken scratches here. So hopefully your guys's are look better. But bye guys. Are our main opioids that you have. And then we have our classes here as well. So very good. So next week is anesthesia. Okay, so we'll kind of, for anesthesia, we're going to continue talking about with anesthesia some other drugs that go along with those drugs. So it's kind of nice because we'll talk about what are alpha-2 drugs, what are you know, our benzos, our cyclohexamines, like we said, or ND or MNDRs. What are our tranquilizers, and what are those functions? All of that stuff. So that'll go with it. We'll talk about monitoring components, stuff like that, and then kind of work through all of the content that's in there. You guys can also see, if you guys check out like my YouTube stuff, there's also old videos and stuff in there too. So you can check out those videos, and there's a lot of really great content in there from my old work sessions with people too. So if there's anything that might help you in there, check that out. And I'm just kind of building as we go with a lot of those things. So feel free to message me if you guys have questions and stuff like that. I will remind you though, this Monday and Tuesday, I am going to be kind of out and about the majority of the day. So I will check all of my stuff later at night though. So just kind of be patient because I'm going to be busy with my other job at a practice. But I will get back to you those nights just later at night though. So if you guys have questions. But yeah, great job guys today. You guys are doing really awesome. Any questions before I head out?
Can I ask one question?
Yeah, absolutely.
With anesthesia, are we going to do any calculations, like any drug calculations or?
Yeah.
Okay.
Yeah. So yeah, we do a lot of math as well because I love math. And then there's also a ton of other recordings too, so that especially if you guys still have questions afterwards, there are a ton of math recordings from previously. So you guys can always go to those too and kind of review those guys. And then even after next week, we'll still go back to those math questions and continue to review as we go, because I know after next week, you're not going to be like, I got it down pat, you know, so we'll still continue to review as we go. Plus on the Facebook page, the crash course page, if you guys have questions, put those questions in there, because we have a lot of old people who still love to help you guys out and are willing to meet with you guys one-on-one. I know one girl is like really into math, so she's always helpful with you guys too. Or they'll just throw a question on there and people are willing to jump in and help you guys out. So never be afraid to do that kind of stuff. It helps out. It doesn't only help out you guys, but someone else is going to have the same question. So put stuff on there. And I encourage it from everyone, and a lot of people don't utilize it as much as I would like on the crash course page, but you guys be the first to start the wheel, get it going. So Everyone has CRI issues and drip rates. I will get you guys on those. It's really easy, and we'll do it. It's not.
Thank you.
You guys make it hard, and it's not. But we'll learn it. We'll learn it. You guys will get it. Great. Good job, guys. We'll see you next week. Bye.
Bye.
Oh, bye.